Hi, this is Doug Rex. I'm a gastroenterologist at Indiana University, and I want to tell you about a study that we recently published in Gastrointestinal Endoscopy. The first author is Parsa, and the title of the study is Performance of Radiographic Imaging After Incomplete Colonoscopy for Non-Malignant Causes in Clinical Practice. So basically, we looked here at the clinical issue of when a colonoscopy is incomplete, you don't reach the cecum. What happens out in community practice a lot is that the patient undergoes a CT colonography or a barium enema. So in order to look at the sensitivity of these radiographic studies in this setting, we looked at our own database of patients who are referred to us. We get a lot of referrals for patients with previous incomplete colonoscopies. We found 65 patients who were referred in with an incomplete colonoscopy, had previously had a CT colonography or barium enema. In all 65 patients, we reached the cecum, and we used that study as the gold standard. Now, I want to emphasize that none of these patients had cancer that was obstructing their colon. They all had an incomplete colonoscopy because their colon was redundant or because they had a very angulated sigmoid colon. The bottom line was that the radiographic studies in this setting didn't do very well. If we consider, for example, patients with adenomas, on a per patient basis, the sensitivity of CT colonography was 63%. On a per patient basis, the sensitivity of barium enema was much lower than that. If we look at a per polyp basis for sensitivity of adenomas, then CT colonography was only at 25%, and barium enema was really less than 10%. It did not perform well at all. So I think the conclusion of this is that in community practice, when the indication for the procedure is identifying polyps, screening, surveillance, many of the diagnostic examinations, and the exam's incomplete, the best approach might be to actually schedule a repeat colonoscopy, use some of the techniques that are proven in this situation. In the patient who has a redundant colon, that means using an adult scope, water filling of the colon. In a patient who has an angulated sigmoid, using a pediatric scope, or if necessary, an even thinner scope, and again, water filling. But get to the cecum with a colonoscope. That's maybe more effective. Another alternative, of course, is to refer the patient to a referral center where you've got confidence that the colonoscopy can be completed. That may be a better approach than going to a radiographic study. If the indication is to rule out cancer, we can't really say from this study. We only had one cancer detected at our center that was in the cecum. Actually, CT colonography did not detect that cancer, but we don't have enough cases to comment about cancer sensitivity. So sort of a rethinking of our usual approach in the patient who has an incomplete colonoscopy, but our data suggests that thinking about repeat colonoscopy has merit in this situation. Thank you very much.